Welcome, everyone, to this April 25th edition of the Newsmaker show. I'm Derek Belinsky, filling in for Brian O'Neill this afternoon, or actually I should say this morning. This morning we have current physician Bill Coch with us out of Allegheny County. He is currently the medical director for hospice in Allegheny County. Good morning, Bill. How's it going today?
Pretty well. I'm no longer the medical director for hospice. I have been in the past. I'm a medical director at Jones Memorial.
Okay, my apologies on that one. I'm just scrolling through your email here. In talking with you, your specialty or your newest interest is end-of-life care. Can you talk to us a little bit about that and what it entails?
Sure. My interest in end-of-life care came from doing 40 years of family practice, where I followed a number of patients basically through to the end of their lives. And it became clear that near the end of people's lives, they often did not get the medical care that they wanted or needed. It often focused on treatment of disease rather than providing comfort and independence for people. And coinciding with this, about 40 or 50 years ago, the hospice movement started, where people have been recognizing when cure of their disease is no longer possible and opted for a different kind of care called hospice care, where the focus is really on treating people's symptoms rather than treating their disease, and trying to make them as comfortable as possible and as functional as possible to the end of their life. And I think that this movement has grown quite a bit in the last few decades, and I think there's still a lot of work to do, but that's kind of how I got interested in all this.
And what would you say the major differences are between this end-of-life care and regular medical care, so to speak?
Sure. Well, when you go to the doctor, throughout most of our lives, we go to the doctor hoping with a problem, hoping they can identify it. Often it's some sort of specific physical problem, and give us advice on what we should do, either just wait and let our bodies heal it, or perhaps a medication, or maybe surgery or something else. And that's the model we've come to accept as medical care. But as people age, there are more and more of these things that we can't fix, and there's more and more that we can't even treat very well. And but I'm sure everybody who's listening has had an experience of somebody who's perhaps in the hospital who's being treated for a specific disease, and nobody seems to be paying attention to how they're feeling. And sometimes all the way up to the end of their lives, that they're still suffering with nausea or pain or spiritual distress, or so normal medical care tends to focus on disease, whereas palliative care, which is a broad term for end-of-life care, focuses on making people feel better, which is really what we should be doing in the first place. That's the whole goal of medical care, really, is to keep people feeling well and as functional as they can be.
And where would you say the best place to get EOLC or end-of-life care?
Well, I think it can be had in numerous places. There are, if you look at about 2.5 million people die in the United States a year, and 3/4 of them are over 65. So they're on Medicare. So we can look to the Medicare data to see where people actually die. In the past, usually about a half or more of people died in the hospital. And if you look back 10, 20, 30 years ago, they died in the hospital, usually still on active therapy, still trying to make people better, often well beyond when they should have given up and focused on something different. Over the last 2 decades, that number has decreased, so that only about 25% of Medicare patients die in the hospital. About 50% of Medicare patients now die on the services of hospice, and about the rest die in a nursing home, which is unfortunate. But perhaps we ought to talk about hospice a little bit. Okay?
I was just going to ask you, you mentioned hospice, and obviously there's some other comparable services. When and how would those come into play?
Hospice services are available through most commercial insurances and Medicare to patients who have 6 months or less to live. Now, I'd like to just digress a moment here to say, well, how do you know when somebody has less than 6 months to live? I think we'd all want to know if somebody thought we had less than 6 months to live. Well, as it turns out, it's pretty much of a educated guess by the doctor about somebody's life expectancy. And actually, this has been studied quite a bit as to how accurate physicians are at predicting their patients' duration of life. And the results are sort of mixed. But if you ask doctors, let's say they've done studies where they take doctors and ask them to go through their list of patients that are seriously ill and ask them how long they think they're going to live. And universally, doctors overestimate how long their patients are going to live. And so in that sense, we're not very accurate. However, if you ask the question a different way, you ask the doctors, this is called the surprise question. Would you be surprised if you got a phone call saying your patient had died in the next 6 months? They're actually pretty good at identifying people who are not going to live 6 months. So anyway, to get on the hospice, a person has to be certified by the doctor as likely having 6 months or less to live.
You mentioned some of these other things. Go ahead.
Sorry?
Go ahead.
Yeah, and so what does hospice do for you? Well, when patients go on hospice, they can get a whole bunch of services that you can't get through Medicare. For example, you can get home health aid paid for up to, I believe it's 22 hours per week, which Medicare does not pay. And these are people who come in and help you bathe, help you get up and get around, can supervise your medications. You get a 24/7 nurse availability to you by phone, and the nurse will come out to your home basically at any time if you're having a crisis. Hospice will pay for your medications without any copay for you that are related to providing comfort for you. And really, in some ways, hospice provides services that would be nice if all health insurances could provide it for chronic illness right along. When you sign up for hospice, however, you also agree to forego basically high-tech aggressive treatments. That is, if you're on hospice for cancer, you don't take any more chemotherapy or radiation therapy. You basically don't go to the hospital any longer, unless you fall and break a leg or something like that. If you have a problem, you call the nurse comes over to your home, evaluates it, calls the doctor if necessary, and make a plan for it. But again, it's focusing not on fixing your disease, because people on hospice, generally their disease is no longer fixable or even treatable. The treatment is focused on making a person comfortable. And most hospice patients are able to die at home, which, of course, the best place to die undoubtedly is at home for most people. Unfortunately, there are a lot of people who really can't do that because they don't have a large family or their family's far away. So hospice does have some treatment facilities. Unfortunately, none around here do, but in bigger cities, most hospices will have a unit that they run where patients can go when things fall apart. Around here, if you're on hospice and your care plan falls apart, you can go into the hospital in a hospice room for up to 5 days of respite care. What would be nice is if you could go for as long as you needed to, but unfortunately, those are the rules right now. But most people who have been on hospice are very satisfied with the care. They feel that that it's been a meaningful experience for them and their family, and it certainly has grown from 25% of people dying on hospice services, I think in 2002, now 44%.
We are talking with Dr. Bill Coch, a physician out of Wellsville's Jones Memorial Hospital. Stay with us. We're going to take a commercial break and be right back after this. Welcome back to the Newsmaker show for this Monday, April 25th. I'm Derek Belinsky filling in for Brian O'Neill. With us today we have Dr. Bill Coch out of Wellsville Jones Memorial Hospital. Welcome back, Bill.
Thank you.
Thank you for joining us today. What advice can you give families who need to talk to about the potential death of a loved one or approach this difficult conversation?
Well, I think this is a really important topic. And a lot of the problems with end-of-life care, I think, can be solved by talking with your healthcare provider about what it is that you want as the end-of-life approaches. In the past, this has been done informally, but in the last maybe 15 years, healthcare providers and hospitals have taken a more aggressive approach to finding out what people want. And these days, the best way to do that is through something called a MOLST, M-O-L-S-T, which is Medical Orders for Life-Sustaining Treatment. And this is a form that people fill out, and should fill out if they have chronic illness. I'm not sure it's for everybody. I think most people are familiar with the concept of both advanced directives, where you say if you want to be resuscitated or not, and a healthcare proxy, where you can designate somebody to make decisions for you if you are unable to make healthcare decisions. But a MOLST form goes beyond that, and I'll tell you why that's important. The Do Not Resuscitate order, for most people, really isn't that important because resuscitation mostly doesn't work for people who are old and sick. Resuscitation is for people who've just had a heart attack or who have drowned in cold water, or there are a number of other situations, but mostly CPR for the elderly, especially the sick elderly, doesn't really work. But what a MOLST form allows you to do is to define whether you want resuscitation, for one, whether you would ever want to be put on a ventilator machine. Breathing machines actually do prolong life. Not always good quality life, but they do. It gives you the opportunity to specify whether you want to receive artificial nutrition, whether you want to receive a feeding tube, whether you would accept devices like pacemakers, whether you wish to be transferred to a hospital for care. And again, these are things that you can do before you're at death's doorstep while your mind is still clear. And it's important because your family then knows in a very specific way what you want. And oftentimes families feel that they want to have more treatment for their loved one, but if it's specified that in no way do they want this treatment, they pretty much have to go along with it. And also it relieves families of the burden of guessing at what their loved one wanted. So getting one of these MOLST forms filled out, I think, is a great idea for people as they get older, especially as they get sicker. They have them at doctor's offices. They have them at hospitals. You don't need a lawyer. It does have to be witnessed, but it can be witnessed by anybody. And as of January 1st this year, Medicare will pay the doctor for you to go in for a visit just for that. You don't have to take care of any other problems at the visit. You go in, you speak with your healthcare provider about what you want, and fill out the form with them, and they keep it on file. It's on file at the hospital, and it really is the best way for patients to get what they want as the end of life approaches.
As a follow-up to all of that, has there become sort of a checklist for dealing with dying patients?
Well, that would be number one on that. I don't know that there's a formal checklist, but those are some of the issues that you would want to address. For dying patients, their spiritual needs need to be addressed, often getting their minister or some minister, if they don't have one, involved is helpful for people. Hospice has ministers on staff, social workers, people who can deal with insurance problems. Often legal counsel is needed near the end of life. Many people don't take care of their wills until the end is near, and sometimes even after they've had the capability to do that. So all that is important for people to get done.
I noticed in your email, and I came across this in my research as well, but back in 2015, as a political commentator, Sarah Palin posted a Facebook message about death panels and faceless bureaucrats deciding who lives and who dies as the government rations health care. What are your thoughts on that?
Well, that was a classic political, they just renamed it a death panel. What it is exactly what I said, where Medicare will pay the doctor for you to go in and discuss this with them. Nobody has any interest in, getting people to either take treatment or not to take treatment. It's really patient-driven. So something that is, in my mind, very essential for people nearing the end of life became a death panel and a political football. And it took years to undo that public relations disaster that it created. But as of January 1st, it is now an accepted reason for a visit.
Thank you, Doctor, for joining us today. Dr. Coch out of Wellsville's Jones Memorial. Just quickly, what are some final thoughts that you'd like to leave our listeners with today?
Well, one thing is I'd like to put in a plug for comfort houses. Comfort houses have grown up. There's 2 in the area that are really great places for people to receive end-of-life care. There is the Heart Comfort House in Wellsville and St. Vincent's in Wayland. These are places that are run by volunteers. There's no charge for these. And universally, people who have spent their last days there have found it very beneficial for them and their families. It's really for people who have 3 months or less to live and don't have other resources to take care of them. And if anybody has any interest, you should go visit them because they're willing to show people around, and they're really great places.
I appreciate your time, Doctor.
Thank you very much.
Thanks for joining us, and have a wonderful day.